Well, first of all, thank you very much for asking me to talk today. And then I sort of thought about that. Actually, I was quite nervous about talking today, and especially when I was given this topic. And I wondered whether I should give a talk about, sort of technology. And if you look at this slide, you'll see some quite interesting pictures. This actually is a 3D printer. And any of you who read your Weekend Australian will know that 3D printing is now extremely important in medicine. And we've recently seen that a new vertebra for a patient has been printed on one of these 3D printers, and the company that does it is Australian, and in fact is supplying body parts across the world. So are we going to see a heart and a lung being 3D printed? Well, maybe. And then there's this rather odd picture here. Some of you may remember that within the last sort of 18 months, there's been a huge interest in stem cell therapy, and Melissa Little from the Institute for Molecular Bioscience at the University of Queensland has developed the stem cell small kidney. So this is an actual functional kidney made in the laboratory. Are we going to see lungs made this way using stem cells? Well, maybe in combination we're going to see something like that. And these are both Australian technologies to a certain extent. We've all taken part in some of this in this sort of new drugs, the new development of therapies. So was I going to talk about some of the new science? Well, when you're in trouble with trying to think of what to say and how to deal with it, you call a friend or you ask. And I'm a clinical researcher, so I thought I would ask around, and I took a convenience sample. So this is not a very good scientific study, and I'm going to share with you some of my findings. So I took a convenience sample around my clinic. This is the mother of a 4-year-old with severe cystic fibrosis liver disease and severe cystic fibrosis lung disease. This mother said, "There's been a shift in things. We hear about how there are so many more adults with CF, and they're dealing with complications of getting older with CF." And then rather optimistically, she said, "I hope they sort it out before X gets there." And I was intrigued by her optimism around that, because she's got a very sick child, but I hope she's right, and hope that the optimism can be felt. Now, this is a 13-year-old with CF, chronic Pseudomonas infection and cystic fibrosis-related diabetes. And she said, "I have the other strain of CF. There are no opportunities for me for a while. Things are changing. Now people with CF can't get together anymore. That's good because we don't want to catch bugs from each other." And then she also said, "The future of CF is positive because of the new studies with new treatments." So 3 really important and different things that have already come up today. So having unusual mutations, infection control, and the future being positive because of research. Then a 15-year-old with CF who's actually looking fantastic, but has been in hospital multiple times, and that's what paediatricians do. They try and get rid of infections. So we're bringing patients into hospital more and more earlier, aggressive early therapy to get to adult life with normal lung function and normal nutrition. And this very lovely young person said to me, "Having been involved with CF for 15 years, I've seen incredible steps forward in treatment. If this improvement continues, I would envisage," and these were the words, and I took them down carefully, "that treatment could go as far as eradicating CF. Whether genetic therapy is the treatment to do this, only time will tell." This is the mother of said 15-year-old. "My hope is that there will be much more research into treatments, but more importantly into a cure. I would like to see vast improved life expectancies and a much better quality of life with minimal hospitalization. I would like better recognition of CF by government agencies so we don't have to fight so hard for support, and help like the healthcare card." So very important for young adults. This mother can't work full-time, and this family would certainly not be able to afford drugs, the kind of large burden of drugs that is required on a daily basis. Our Respiratory Fellow, gene-directed therapy and treatment of the underlying cause of CF is changing the future, which is really exciting. Young doctor, very excited, it's great. What about the nurses? Well, I went to lots of different nurses, to the research nurses, to the ward nurse, and to our CF nurses. Things have changed so much over the last 10 years in the wards. We now have much younger children rather than lots of teenagers, and that's getting back to the aggressive therapy. So things have changed in Australia. We're bringing in young patients. We're dealing with things a lot earlier. We need to consider the burden of care and improve home care. CF care is so overwhelming for so many parents. We need to simplify things and reduce the burden of treatment. New studies are changing things for CF. We need more preventative approaches and better education for families. And we need to reduce the burden of treatment with smarter delivery devices for inhaled therapies. The larger numbers are a struggle, and personally I feel I can't deliver the care needed because of the numbers, and that's from my clinic as a CF nurse. Clearly there are issues. This is from the doctors. We're doing better and better, so many patients now never need admissions. There's been a transition from paediatrics to adult disease, and adult services are under-resourced. So even the paediatricians are recognizing that. Research funding for CF is not enough when you compare costs of cancer patients per research funding. I feel isolated and not part of a team anymore. I need a forum to discuss patients, and my workload is too high. We're letting down patients in regional centres. We need a better model of care for managing regional patients. Physios. We're doing well, and adult numbers are going to be top-heavy. Resources for adolescents and adults are a problem. When children turn 16 in Queensland, many lose their healthcare card and can no longer access subsidised airway clearance equipment. And we need to advocate for better access for adults with CF. We're getting near the end of these, but you're starting to see some themes. Respiratory scientists. Spirometry may no longer be the greatest measure for following children with CF. Now that was interesting. It's not sensitive enough, and we need new measures, maybe LCI or other measures. Patients are living longer, and longevity is the biggest issue with maintaining quality of life and respiratory health across adolescence and adult life. And then the cost of care is a burden for patients, and drugs are a huge cost for society. So there are a number of themes that you can see. We're doing better, optimism. Research is of key importance in Australia, and the CFTR modulator therapies have obviously brought huge hope. But there are burgeoning adult services, and that's a huge issue across paediatrics as well. The burden of care is high, the cost of care is high, and our models of care may need to evolve. Some clinical outcomes that we use may also need to be reconsidered. And clinic teams are important. We heard from Nathan Charles how important teams are. But size changes things, and my clinic morale clearly needs some work. So let's quickly look at what we've got along these themes. Well, steady improvement, you've seen this today, and now the median age of survival, or predicted age of survival in 2013, CF Foundation was put at 40.7 years. But there are challenges, and I pinched this slide from Sarath Ranganathan many years ago, and I have found it very useful. And what you can see are the cohorts from 1990 and then from 2009. And obviously the blue is the 2009 cohort. And what you can see is that all the way across, there's been an improvement, but the curves are parallel. So where's the improvement been? It's mostly been early on in life. And we need to do things sort of better, particularly in this rather frightening period of time in adolescence. But to do that, we need to keep working down here, but we also need to work here very, very carefully. And if you think that's just in the US, no, the Australian data are exactly the same. So our challenges here, we need to understand early life determinants, but we also need to understand what happens in adolescence. We need to understand the development of lung disease. We actually still don't really understand that. And we need to understand the relationship with the outcome measures that we're taking. So we've been through that, so I'm going to skip that and just go straight on to CFTR modulators, because these are what are now available in the clinic in the US, and some of these, or ivacaftor, is available in the clinic here. So if you look at this timeline, back here in 1989, the CFTR gene was discovered, and we've come all the way through to 2015, when we've got the results now published for Orkambi, lumacaftor plus ivacaftor. And along the way, you've had all these various different phase 1 trials, phase 2, and then phase 3. And you can see that there's been about a 10-year period between the phase 1 studies starting up here and now the phase 3. So it takes a long time getting a drug actually to the market, and this has been a remarkably quick process for these two products. Now I'm going to go back to ivacaftor a little bit, and Barry gave a wonderful account of all of this. But this is a new paper that I think is the first to really give us an idea that these are actually disease-modifying, or potentially a disease-modifying therapy. So far we've seen that the drug really improves things, but in the relatively short term, does it change what happens? Does it just shift your curve a little bit and the same thing happens over time? What actually happens? So Sawicki et al. Just published in the Blue Journal this fascinating study, and what they've looked at are patients who were on clinical trial drug, and then they've taken controls from the CF Foundation registry, and they followed them over a longer period of time. And what you can see here is that the two groups, so these were the ivacaftor, the grey are the controls, who were homozygotes for F508del. And so this is the starting point, and you can see that the homozygotes had a slightly better lung function at baseline. And then they started the analysis from the point at which you see the first improvement with ivacaftor, and then they followed them over time. And what anybody can see fairly clearly is that these two lines are actually diverging, so that the fall in lung function, which does continue to occur over time with ivacaftor, is less. And it's important to recognize two things. One, it's disease modifying, and that was statistically significant, but there is still a fall in lung function. So these are wonderful drugs, but they're not going to fix the problem completely. And then you come to the Orkambi data, and this was a far more modest outcome. It was, however, extraordinary in its way, in that the problem is also far more complicated. So what we're trying to solve here is the F508del mutation, and that isn't just a class 2 mutation, it's class 2 plus class 3 plus class 6, so it's got a whole bunch of problems. And yet, there was a shift in the whole population. Now, these are not the actual data, this is a modeling of the data, so just be aware of that. And it was a modest shift but to the right of the whole population. And what's extraordinary about these graphs, and it's the picture that gave me the shivers when I first saw the data, is that it was the recognition that these types of therapies affect the whole population. So for drugs in general, we've been used to responders and non-responders. That is no longer the case with targeted therapies. These therapies that affect the whole population, they shift the whole population. So we've got to think differently about how they're used, I think. And just looking at pulmonary exacerbations, and I'm not going to go through this in any detail, but there was an improvement in exacerbations as well. Now, moving on to class 1 mutations, they've been hard done by, really. And what are we going to do about those? Well, there's a very interesting paper that came out in 2014 that suggests that we may have some early possible clinically relevant approaches. So we know that aminoglycosides can improve class 1 mutations, and this study looks at how synthetic aminoglycosides, which have less or thought to have less toxicity, with ivacaftor might be the solution. So those sorts of studies are going to be on their way. So this is just the beginning. New correctors are being tested, new potentiators are being developed, and combinations of different classes of correctors are now being looked at, which may really work better for improving F508del. Now, this is a complex picture, But it's a fabulous paper, and I think what it really tells you is the excitement around the science in this area. So organoids have been mentioned. Fantastic to be able to test those patients who only have the chance of having studies done in very small numbers of patients. We can't do it when we've got n equals 4 or 5. Very difficult to do those sorts of studies. How is my patient, my young 13-year-old, going to get a new drug? Well, I'm hoping she'll get one when this becomes available and we can test them out on her organoids. What about monocytes and lymphocytes? We can get those pretty easily from peripheral blood. CFTR functional assays are now becoming available. That's going to be very exciting. And then there's this whole world here of CFTR repair, where we might be able to repair and actually transplant some of those epithelial cells. That's going to be a fantastic opportunity down the track. So I think the science and technology is awesome. But then themes, going back to the themes, the burgeoning adult clinics. And these are data shared by Scott Bell, so thank you very much, Scott. And I think he's going to be showing you these data tomorrow as well. But he's kindly given me this slide because what I wanted to show you is the rather frightening number. This is great news, of course, but it's frightening from the point of view of what we're going to do about it. So back in 2001, 150 patients, now over 300 patients. That's a massive increase over time. And so we need resources for that. And as Barry pointed out, this is occurring in Europe, this is occurring around the world. So these are from this fabulous paper that Barry mentioned by Burgel. Looking on this side, these two graphs here are different groups of European countries and the adult numbers, and this is a projection into the future. You can see in the squares, the pediatric centres in the circles, and this is the combination here. And when you put the two graphs together, you get this increase here. So you've got an increase of about 20% and 50% approximately by 50% in the total population, which corresponds to an increase in 20% in the children and 75% in adults here. So there's an increase across the population, and that's something we're really going to have to work towards looking at how we manage. Now, the burden of treatment is high. That came across as a major theme in my investigation. The use of chronic therapies. We've got more and more therapies, and we keep adding more, and we take off little. And the problem is that all the studies are done on top of all this therapy because you want to do it in a well population. You need to show benefit above conventional therapy. So we've got all this therapy, we add another bit. Are we going to get the last straw that breaks the camel's back? Every time we add something on, we add burden to the clinics, we add burden, more importantly, to families and patients. And when we're doing this more and more earlier and earlier on, there's a mental health burden to that. We're seeing more and more troubles for young children struggling with all the therapies we're piling on them. What about costs? I'm not going to go into this in detail, but very nice new papers from Australians, Van Gool et al., looking at the cost of care in Australia, and this is without the new drugs. So it's a significant cost, and a very nice new paper that's looked at every drop, every 1% increase in FEV1 drops the cost, so improving health improves outcomes. But chronic infection has a massive impact. We really need to prevent chronic infection because that does have a massive impact. And I haven't got time to talk to you about non-tuberculous mycobacteria, but that's starting to become a major player. Pseudomonas, perhaps less so in pediatrics. Non-tuberculous mycobacteria is certainly increasing. And I'm not going to really talk about new drugs, except to say that it's changing the way people look at therapies. So we're already seeing that doctors are starting to worry about prescribing drugs because of costs. People are confusing, in some ways, their societal hats with their medical hats. We've also got the ethics of writing those prescriptions when you know you've got a non-adherent patient, and it's the cost to society when you make that prescription. Those things are all starting to be important for us as clinicians, and we're going to have to think about how we manage that into the future. We want drugs, we want new drugs. How can we afford them? Models of care. We've got patients all over Australia. Now, many of you, even the Australians, forget how big Australia is. This is where my clinic is in Brisbane. We do outreach right up to Cairns. That's not even to the top here. And that's the same distance as about from London to Rome and from Brisbane to Melbourne, actually. So if you think about it, it's just massive. So what are we going to do about all this? All these new treatments require all these new tests. They require a lot of involvement of the clinics. Well, telehealth is very important. Outreach is important. And telehealth, I think, is going to get bigger and bigger. And certainly in Victoria, they're now using telehealth with patients in their homes. I think we're going to start to have to look at a lot of these new models. IEMRs, most of you, I'm sure, have started using electronic medical records. Most of us swear bitterly at them. They cause all sorts of headaches. But we're going to need to get much smarter about using them. We're going to need to have them connected so we can use them for research. We're going to need to look at sharing positions, hospitals in the home. And then there's this very interesting idea, e-mental health should be offered to patients from the start. There's now getting to be quite good evidence. And if you want to have a look at the case for action for the use of e-mental health, the NHMRC has a very nice website on the topic. What about shared decision making? Well, there's some very interesting ideas on this. This is also an Australian from Bond University, published in JAMA about shared decision making. Shared decision making makes common sense. We all think we do it. How much do we actually do it? And sometimes people don't want it. So this is a very interesting article just in the recent New England Journal of Medicine, which you might want to read, looking at how sometimes a paternalistic approach might also be a good thing. So there's some differences across the medical world. Well, outcomes are changing. And this isn't just to make you sit up. FEV1, lung clearance index, that new outcome. Well, chest CT scanning, is this going to turn into MRI with no radiation? Induced sputum, very important. We've heard a lot about new approaches to looking at sputum. What about young children who can't actually expectorate? Electronic noses, or maybe the dog. Now, dogs are now starting to be able to sniff out cancers, melanomas. They're better at picking out men who have prostatic tumours. So if you pass a urine and pass it around the dogs, they're actually better able to pick it out than if you do the other sorts of testing. There's all sorts, even lung cancers are now being picked up by dogs. So it may be that you come to the clinic and stand in front, a bit like going to the airport, you know, the dogs get on the luggage. Instead, your child walks past the dog and the dog barks. You're in this room, you're in that one, you need this treatment. I think it'll be exciting. pH capsules. It's going to be the new way. I hate all that manometry and pH probes. We need to start doing that better. And now the really difficult theme, clinic teams, expertise and experience without burnout. What about sizing of clinics? Small clinics, limited experience, how small is too small? We're struggling as specialist teams, dealing with regional non-specialist teams, keeping families on board at a distance. I showed you how big Australia was. We need to get a lot better at doing all of that. We have huge staff turnover in our regional centres, but also even in our CF centres, people move around. Dealing with stress, everything getting bigger is quite stressful. Managing professional boundaries, that's also a huge problem in some CF centres. At the end of the day, you look after patients for a very long time. You have to separate out being friends with those patients and having a professional relationship with them. How big is too big for a CF centre? At around 250 patients, my experience was that we lost corporate memory, and that was when I was at the Royal Children's Hospital. Now we're 430 patients, and we certainly don't have corporate memory of all those patients. We also have a staff of over 30 people, a team of over 30 people, and we have 11 doctors to keep track of, so that's herding cats, that really is. Now, we also have a lot of part-timers. Nobody's there on the same day. How do you ever have a meeting? How do you ever decide anything? It's extremely difficult. We're going to have to evolve. We're going to have to take on this challenge. And one of the great things about doing this talk was that I went round and asked my clinic what they thought, and I found out. So I'm going to have to rethink what we do and invigorate our team. We're going to have to do it better. So we've made amazing progress, but we've got some way to go, and thanks to Scott Bell for this slide as well. There is a patient with cystic fibrosis climbing up here. So you can see he's made a lot of progress. But it always comes back down to this for me. It comes down to the child in front of you. And one day, I want us to not know which is the most likely to be the patient. It'll be very exciting when young babies have as much chance of turning into grandparents as everybody else. And my huge thanks to the patients and their families and my awesome CF team who shared their insights with me for this talk. So thank you.